This episode of GT the Podcast is supported by Alcon. Welcome to Dose and Delivery, the podcast. In this episode, Dr. Paul Singh welcomes Drs. Davinder Grover and Nate Radcliffe to discuss target IOP ranges, the utilization of hysteresis to assess glaucoma and predict pressure fluctuations, as well as some of the technologies available for measuring IOP. More on this from Dr. Singh on Dose and Delivery.
Hey everybody, thank you so much for joining us. I am Paul Singh out here in southeastern Wisconsin, proud cheesehead and glaucoma dude. And I'm here and honored to be hanging out with two fantastic colleagues, friends, surgeons, you name it. We have Davinder Grover out in Texas. What's up, Davinder?
Hey, Paul. How you doing?
Good, man. Good. And we also have our good friend, one of the funniest guys I know, Nate Radcliffe out in New York. What's up, Nate?
Great to be here tonight, Paul.
Thank you guys for hanging out. Yeah, it's a nice late night for you guys on the East Coast. So thanks for joining us here. But thank you everybody for another episode of Dose and Delivery Podcast Edition. We're going to have some fun tonight. These are two really fun colleagues of mine who are going to probably make it more fun than I could ever imagine. And we're going to start us off talking about the quintessential question we all have to ask ourselves when we see a new patient come into our office. Where do the target pressures have to be? And I'm going to make this really basic and simple as a question to you guys. We're going to take it anywhere you want to go. But, when you're sitting in your room, just give me a quick spiel if you can. Let's say we'll start with you, Davinder. When you have a patient in your room, how are you assessing target pressures? Give us, just for everybody's sake, some of the key salient features of that patient that makes you appreciate what the target pressure should be.
Yeah, Paul, it's interesting. The target pressure is such a fascinating topic. And, it depends often if we know like the patient's highest pressure, their Tmax. Typically, by the time they come to my practice, I don't know their Tmax. So I usually basically will think about their stage of disease. And if they're in the advanced category, I'll just put them immediately. My target is less than 15. If they're kind of mild or moderate, I'll usually aim somewhere in the mid to upper teens, depending on the stage of things. But if I do know their Tmax, I will typically just try to target a 20 to 30% reduction. But it's in flux. But I find myself targeting more, on the go, just a new patient, kind of mid to upper teens.
Thank you for tuning in to another episode of Dose and Delivery, the podcast.
Unless I have some evidence
or topic
progression, then I can use that to refine
find us on Glaucoma Today's
range.
Instagram, LinkedIn,
I'm gonna get back to that
Facebook, or
good
Twitter.
Points there.
Stay tuned for more hot topics and glaucoma care on Dose and Delivery, the podcast.
I actually sounds like I do the same thing as Davinder, which is,
yes.
Yeah.
It's automatically right.
Yeah. There's like a 3-hour answer to that question, but the 10-second answer is, mild glaucoma, high teens, moderate glaucoma, mid-teens, severe glaucoma, low teens. And I tend to kind of immediately start there, and then you start asking all the nuanced questions. How easy is it going to get to the low teens? What's their hysteresis? What's the patient's history? What was their Tmax? What did they progress at? You start with this really simple framework, and then you just decorate it with all these different nuances, sometimes over many visits or even many years or perhaps even decades.
So real quick, I'm going to, before we get into the details of like what technologies, what are some of the different risk factors that you take into consideration, do you guys give your patients target pressures? Do you actually tell them what the range should be that or you want to achieve?
I usually do when I'm recommending therapy. Mainly it's because I'm saying, your target is somewhere around here, and this is where you are today. Where that gets to be a problem, which is, I wonder if this is where you're going, is half my patients today probably had borderline pressures. And, I could neither say they were outrageously out of control, nor could I say I was happy. And I wasn't necessarily recommending any brave, intervention. And I usually don't tell those patients, that I'm sort of mediocrely satisfied with, where they are at that visit. I try to give them hope, but I think that is the downside of giving, target pressure.
How about you, Davinder? Do you give your patients an idea of where you want them to be?
I do. I think pressure is just one thing that they really wrap their head around and they get focused on that number. I don't like to be as absolute. So like what Nate was saying, it's more I think tolerable and acceptable to give a range. Say, hey, I want you to be in the upper teens, mid teens, low teens. So what's the mid teens? Is it 15? Is it 18? Typically we want them 15, 16. But if they're 17, 18, I'm like, oh, you're slightly higher than the range that I want you to stay in. Let's see what we can do. Or if they're in the upper teens and I see a little bit of potential progression, then I move them to the mid-teens, and I tell them, hey, you're kind of floating in the higher area than I'm comfortable with. Let's intervene and try something to get you into a slightly lower range. So I try not to let them focus on one exact number, because some do, and we all have those patients where they come in with a notepad, and you're like, what's my pressure today, and they write it down and they get so focused on it. And I try to give them I tell them this oftentimes when I have the perspective of a couple of years. And I say, what, I don't really care what your pressures are today. What's more impactful to me is that I can look back over 3 years and see that we have stability. So wherever we've been going over the past 3 years, we're good. We could have been going up, from 15 to 18. But so don't get focused on the fact that your pressure is 18 today, because I can take a step back and say over 3 years, we've been stable. And that's the most powerful thing about today's exam.
Speaking of fluctuation, what tolerance do you have for fluctuating IOPs? What will you tolerate? Let's say, I know it's a difficult question to answer because of depending on severity of disease, but are you happy with, 2 or 3 millimeters of mercury, or do you start to get worried and start to intervene regardless at like 4 or 5 millimeters of mercury? So what's your threshold for saying this is not controlled based upon fluctuation?
I was influenced by Jeff Liebman, my fellowship mentor, and he had a nice paper looking at something like 10,000 visual fields done in New York City, and he did pointwise linear regression on all these fields. So he ended up with something like 300 patients with more than 5 fields each, and could really drill down on risk factors. And he found that the Tmax, so the peak IOP was one of the best risk factors. And fluctuation was in there, but it wasn't as important as the single highest pressure in the chart. So I kind of hung on to that in that study. He also found low corneal hysteresis, not just to be a big risk factor, but also to be to be the only risk factor that mattered if you considered both hysteresis and corneal thickness. So it kind of knocked corneal thickness out of the model. So I tend to latch on to the highest pressure. Interestingly, when we get to hysteresis, you'll see a relationship between hysteresis and fluctuation at times. But I tend to be the doc who doesn't let people have their gimme. Well, you know what? I didn't take my drops Thursday, and now I'm just here with a high pressure, but I know how to fix it. For me, that's actually that's it. You now need an intervention because it's shown that one pressure is when you progress, and that's it. Now you've crossed the threshold.
I think I'm more of a pushover. I second everything Nate said, but the line I use is I say, hey, I give you one get out of jail free card. All right, you come in one time, your pressure's
so generous.
and then after that, then I'll pull the trigger. But I give them one chance, basically.
Yeah, I mean, the reason I asked that question is because I read an article from, we all know the advanced glaucoma interventional study, the AGES study showing fluctuating IOP in a more advanced population, risk factor for progression over 100 months. But for me, what really kind of went like a blue kind of like wow factor moment was when I read that Caprioli paper in 2008 that showed that if you separate the two cohorts in the AGES study, average pressure of 11, patients who had an average pressure of 24. And you look at the patients who fluctuated in the average pressure of 11, right, which is so hard to do in advanced patient population over 100 months. If you had an average pressure of 11 but fluctuated with less than 3 millimeters of mercury, you had a 9% progression rate. If you fluctuated with an average pressure of 11 but fluctuated more than 3, you had a 30% progression rate, which incidentally was the same progression rate as if you had high pressure of 24 in that study. So I think, to me, the more advanced we get, the more I think we start to see fluctuating IOP become a risk factor, like CIGIS and AGES, versus in OATS and those other earlier studies. We don't see it because you have so much more ganglion cells. It's hard to see field loss as a risk factor. But that's why I start to get more concerned when I see those kind of patients. But to earlier the question, I do give target ranges. I think, to your point, not a specific number, but I think it's a great way to give them some context. When a patient comes back, you start the therapy, they come back and like, doc, am I at that range? Yeah, you're at that middle teens. Congratulations, keep on that drop. Or remember, Mrs. Smith, when we said you had to be back in the teens, well, guess what? You're in the 20s. We got to do something more now. We got to start. So it gives me a springboard to talk about that next intervention. So I do think it's important. And I always tell them this is an evolving and it's an ever-changing target range depending on how stable you are with your other tests that we do as well. So, but thanks for that info, guys. I want to also ask a question. So, we talk about the different risk factors, right? Age, and there's always obviously secondary issues like exfoliation, et cetera. Let's just talk about the most common ones that we see. How important, I'm going to talk about two main ones that a lot of people are using. One is, of course, pachymetry, and one is another one that not everyone's using, which I think everyone should use, is corneal hysteresis. But real quick on pachymetry, how do you use that now as we've gotten so much more data in the last few years? And now that we have hysteresis, we'll talk about that in a second. Do you still use pachymetry? Do you still get it? And what does it mean in your algorithm?
I use pachymetry, but I really I focus more on corneal hysteresis now, because I kind of think of pachymetry as a poor man's hysteresis. Really, I think hysteresis is much more sophisticated, and it's what central corneal thickness pointed to when we didn't understand the biomechanics of the eye. But for example, when I'm classifying a patient's state risk, if they're a glaucoma suspect, I will, although I don't think it's broadly accepted that hysteresis is a risk factor, I think it's broadly accepted that corneal thickness is a risk factor. So in the chart note, I will say a patient has low corneal thickness just because it's traditionally considered a risk factor based, for example, the Oates calculator. But in my mind, I don't ever use pachymetry often. Not ever, but I rarely use pachymetry as in a decision-making process unless they're on the extreme of like 420 or something like that. But I will always use corneal hysteresis in my decision-making process, because I do think that it's a glaucoma vital sign. And Paul, like you said, it's something that I think everybody should be using, given the data out there showing how closely it's tied, the biomechanics of the eye, the corneal hysteresis, how closely it's tied to risk of getting glaucoma and getting worse with glaucoma.
Okay, so I try to avoid the topic of hysteresis long enough. Here we go. I tried, man. It took me like 15 minutes, but all right. So we have two amazing hysteresis specialists here, so I could geek out for a long time. Nate, just for the audience, give us a quick spiel. What is hysteresis? What is it really measuring for the average patient out there?
So, I think I'm not an engineer, and so I look at it as a real simple measurement first, and then I kind of try to figure the rest out from there. Hysteresis is if you're using an air jet tonometer, okay, which is a puff of air that ramps up from a very low pressure to a high pressure, eventually applanates or indents the cornea, and then ramps the pressure back down. The hysteresis is the difference between the pressure at which the cornea indents and the pressure at which it goes back to normal. And, if you have a nice fancy mattress like Paul Singh, I'm sure does, he can
sleep on the couch most nights nowadays. It's like,
you push your hand into that mattress, it's going to indent, and you're going to take your hand away, and it'll be a moment or two before that mattress goes back to its normal shape. And it's because the mattress has absorbed, it's viscoelastic, it's absorbed some of the energy from that push, and it's just taking time to sort of return to its normal state. That's hysteresis, and hysteresis tells us, in my mind, a little bit more about the cornea's behavior. And I use the term behavior because, unlike corneal thickness, which is a geometric property, the behavior of the cornea tells us how it acts, and it also implies that it is dynamic. It can be under conditions of stress and behave differently, and indeed, things such as treatment, intraocular pressure, age, all influence hysteresis as it changes over time. So it is a biomechanical assessment of the cornea's viscoelastic properties. And as it turns out, it tells us about the patient's likelihood of getting glaucoma, their likelihood of progressing if they have glaucoma, and even some other neat things about IOP, how the pressure responds to therapy and beyond.
So we're going to get to that response to therapy, because I know you've done some great work on that as well. Davinder, can you honestly say then, could you explain it by saying this is like the shock absorbing ability of the eye and the ability of the lamina to absorb kind of pressure forces? Can you describe that some more? How do you correlate it with the nerve in the back of the eye?
Yeah, of course. Well, first, I think I understood about half of what Nate said, and I wish I understood hysteresis to understand it. But I think of it as he has, that was just a perfect way of describing it. But yeah, the way I wrap my simple mind around it as really just thinking of the shock absorbing ability of the eye, and eyes that are great shock absorbers are less likely to get glaucoma and get worse with glaucoma, and eyes that are poor shock absorbers really feel the brunt of the insult from the pressure and aren't able to cushion that blow. And I think as Nate was saying, that we measure it by looking at the front of the eye, but it really kind of I think gives us a sense of the entire eye as a spectrum and what's going on the optic nerve and the lamina, and thinking how the lamina and the optic nerve respond when the pressure is elevated. So I try to just take a very simplistic understanding, because I think that the concept of hysteresis is when biomechanical experts hear me describe hysteresis, I know they cringe because they understand it on a whole different level. But the way I kind of understand it and the way I try to explain it to my patients is really just get simple. Shock absorbing ability of the eye. We want to know if your eye is a good shock absorber or a bad shock absorber. If it's a good shock absorber, you're less likely to get glaucoma and get worse. If it's a bad shock absorber, you're at a higher risk. And the worldwide average, is about 10. Above 10 is good, below 10 is bad. And that's kind of, I think, the simplistic way I can understand it and appreciate it. And I use that on a daily basis. And I think it's easy for me to explain that to a patient in clinic in a matter of 5 or 10 seconds, where I think they understand why the heck doing this puff test on their eye and doing this additional test on them.
Yeah, I mean, the way I describe it to my patients, like a good shock absorber, it's a smooth ride. If it's a bad shock absorber, you're feeling every bump and it really hurts. Well, your eye is hurting when you have a bad shock absorber, it's low. So that's my simplistic way of looking at it for my patients. But so you mentioned that above 10 bad, below 10 good. So if you can. No, I'm sorry, above 10 good, below 10
below 10 bad.
All right, see, it's a late night for me. Yeah. So above 10 good, below 10 bad. Sorry. So again, everybody, above 10 good, below 10 bad. So give us some scenarios, like real life scenarios. So where has it really impacted you? Because one of the questions I hear from a lot of my colleagues is, hey, great, but when am I going to use it and how do I use it? So Nate, do you have any cases that you can describe for us where it helped you?
3 hours ago, I saw a patient, and it was a diabetic, and the patient was on 3 drops and had a pressure of 24. But there was a lot of diabetic edema, and the OCT was, for lack of a better word, just not helpful in terms of telling us how much, RNFL atrophy there was, because the edema was swamping it. And, you get in these situations where it's really tempting to start chasing after the pressure because you've lost your radar. When you don't have an OCT, you're kind of like flying, blind. And, in this particular patient, we had, because every patient in this practice gets the ocular response analyzer, I had the hysteresis. It was 11.5. As Bob Weinreb did a study, part of the DIGS, or an extension of the DIGS study, where he looked to see really, how people's visual fields progressed, and he divided them into a low and high hysteresis group. There were no rapid progressors in the high hysteresis group. And in fact, the average slope in the high hysteresis group, even though some of them had glaucoma, the slopes were flat. They weren't even getting worse. They certainly weren't getting worse quickly, and they weren't really even getting worse over 3 or 4 years. So it's a get out of jail free card on some level. And for this patient, the high hysteresis was enough to not only help me decide not to escalate therapy, even though they're at 24, but to back off their drops and see if we can't keep them probably still with a pressure of 24 on just one of those 2 drops, because the other side of having a high hysteresis is drops don't typically lower your pressure that much, because there probably isn't that much pressure to lower.
Nate, I think that's such an amazing example, because there's always a tendency, especially as we talked about at the beginning of the session, with focusing on pressure, And, when a patient hears the pressure's, 23, 24, they're chasing that low number. And as physicians, we also almost want to chase that number too. But, there's nothing I love more than stopping drops. And if you can have a patient with a high hysteresis, exactly what you described, you can watch a 24 and be comfortable because and you can show them and explain to them that. It's so powerful, and it gives them comfort. It gives us comfort too.
Yeah, today, same example. I had a patient referral, pressure 25, patient's 36 years old, healthy nerves, healthy fields. Now, in my experience, if they have a hysteresis of 12 or 12 and a half, like this patient did, I'm okay to come back in a year, you're fine. If their hysteresis was like 8 or 9, I'm treating them. And that's how powerful it is for me as a decision-making process. If that same patient, low hysteresis, I'm treating them. If they're high hysteresis, I'm watching it for a year. And I think that's kind of how powerful to me it is. And, Felipe Medeiros has done some great work at Duke showing patients who are, glaucoma suspects progressing to glaucoma. I think you mentioned that earlier, Nate, being more powerful than pachymetry as well. So I think that's really important. And it also, and Davinder, you've done great explanations on this IOPCC, this adjusted hysteresis IOP versus the Goldman equivalent. Can you tell us about what the machine, so we use the ocular response analyzer by Reichert, and that gives us those two values. Can you tell us more about those two values and how you use those in your practice?
Yeah. So, the output of the ocular response analyzer is kind of 4 things. 1 is the hysteresis. 2 is the IOPG, which is what they think the Goldman applanation should be. 3 is this IOPCC, which is the corneal compensated IOP, or taking into consideration the biomechanics of the eye. And then the 4th output is the waveform score. And that needs to be at a decent level, about 7 or 8 or higher. But what's interesting is that, there's more of a discrepancy in my experience, and I'd love to hear Nate's perspective on this too, that Goldman just misses it when the hysteresis is low. And so, I'll have patients that have a Goldman applanation of 11 and a hysteresis of 8.5, and their IOPCC, they're getting worse at 11. And the traditional glaucoma doctor would say, oh, they need a trab, and we need to get their pressure to 7.5. But you do the hysteresis, you do the ocular response analyzer, you assess their hysteresis, find that it's low, and you check their IOPCC, and invariably the IOPC is like 17 or 18. So here you think you're following a patient with a pressure of 11 that's progressing, but in truth, what's happening is Goldman is missing it for some reason. And I think it has to do with the biomechanics of the eye. And one of the reasons why, although Goldman is important, why it's flawed. And I think that's specifically the most powerful thing. And that's probably why there's such a tight correlation between hysteresis and progression, is because we're watching patients get worse, even though we think their pressures are reasonable.
What you just said there, if you think about the Goldman tonometer as also being a pachymeter, and of it just blending the intraocular pressure and the corneal thickness, but not telling you the relative contribution of the two, you see why it's such a problematic way to measure the pressures, because one is good if it's high, hysteresis, the other, or corneal thickness, the other is bad if it's high, intraocular pressure, and Goldman just gives you both mixed up a little bit. And I joke that my favorite pachymeter is, the rebound tonometer. Because you can tell if someone has a thick or thin cornea. And the problem is it's just telling you it's a pressure measurement. It's not admitting it's a corneal thickness estimation. Anyway, that's the problem, right? And that's what the problem we're trying to get. And to your point, when you finally get the relative contributions, the hysteresis here, the best assessment of the pressure there, things start heading in the opposite direction. And you're totally right. Goldman is telling you it's a low pressure because there's a thin cornea. Wrong and not helpful for glaucoma, because we need to be extra careful. Anyway.
Yeah, no, those are great points. I want to tee off on a few of those points you made as well in a second. But there's a number of studies. I think there's about 700 studies I think been done with using hysteresis and glaucoma over the last decade or so. And I think there's some really valuable. Like I think there's another study shows that 90% of our patients who have asymmetric glaucoma have a lower hysteresis in the worst eye. As well as this, I think one other study I think just important to recognize is, to your point earlier, Davinder, about that whole lamina curvosa and the shock absorbing abilities, that there was a study looking at a LASIK ring, putting on the cornea, bringing the pressure up to, I think, 60 or 70, and looking at swept source OCT and showing that the higher the hysteresis, the more the lamina cribosa will bow back and come back to primary position. And the lower the hysteresis, the less it would move as well, showing kind of the pliability of the lamina as well. So I think it makes a lot of sense. And I think when it's high, so you made great points about having low hysteresis and having the IOP-CC being lower than higher than what the Goldman equivalent would be. Nate, what about higher hysteresis and effect on PGAs or IOP reduction in terms of topical drops? Do you find that helps you explain why some people don't respond well?
Yeah, so there's a tricky thing here with high hysteresis. By the way, Paul, I just have to tell you the story. About maybe 10 years ago, I tried to publish a paper that people with disc hemorrhages have lower hysteresis in the eye with a hemorrhage. And that people who have disc hemorrhages are lower hysteresis than people who don't have them. Nothing crazy, right? I couldn't get the paper published. I tried a couple revisions, waited 5 years, and then just resubmitted it, and it got in. No changes.
That's how it works, man.
I just waited for everybody to understand hysteresis.
Wait until Davinder starts talking more about it, right? On the podium. It's like, now it's going to get accepted.
Hey, keep it in mind for some of your early manuscripts, probably ahead of their time. So, okay, so let's take a look at, so why is it when you when you measure with Goldman, let's say you measure with Goldman and someone has a very thick cornea, you get that high 26 and their cornea is 600. You put them on a drop and you may have changed the intraocular pressure, but you didn't change, the elephant, right, in the room, which is the thick cornea. And so Goldman's going to report back, hey, I still had a tough time pushing against the cornea. Pressure must still be high. Well, you changed the pressure, but you didn't change the biomechanics. You didn't change the corneal thickness. And so Jamie Brandt in the Oates study showed a really nice finding that when they started patients on a PGA in Oates, that if they had a low thickness, a thin cornea, they were getting like 30% pressure reduction, maybe 25% pressure reduction from latanoprost. When they had the thick corneas, it was something much less. And I forget his number, maybe it was 20% or 17%. We repeated that with hysteresis and found an even more dramatic difference. Eyes with a very low hysteresis would get good pressure responses from drops, 30% from latanoprost. But the eyes with high hysteresis only had 7% pressure reduction. Now, do I believe that people, remember, high hysteresis, low risk, those people do well. Do I believe that they're not having their pressure drop? No, I think their pressure's coming down inside the eye, but the cornea doesn't tell the story. We kind of played around with this a little bit, and we also found that people with a high hysteresis tend to have less pressure fluctuation. Now, why would that be? Well, maybe it's because they have a low risk of glaucoma and they have stable pressures, but maybe it's because the cornea just sort of reports back the same kind of, artificial value. And so I tend to think of eyes with a low hysteresis are giving you more pressure information. You can see things, you can see the pressure drop. Interestingly, when you do a trab on an eye with glaucoma, the low hysteresis eye will have a greater change in its axial length from the trabeculectomy. So it may be that those eyes with low hysteresis are just under more pressure stress. And when you treat that stress, things just resolve more. We even had a paper at World Glaucoma Congress that we never published on about 50 surgical eyes. And again, a lower hysteresis going into the OR meant better pressure reduction postoperatively. And this was with a variety of tubes, trabs, and even CPCs. So, there's something about the pressure response with low hysteresis. Maybe it's because the glaucoma is very severe. It even gets you thinking about whether intraocular pressure is really the best way to measure this disease that we think of as glaucoma, or if if it wouldn't somehow be better to just assess the stress biomechanically the eye has and kind of go after that.
Nate, what you got me thinking about with that, I mean, what you said was just very insightful. And when it circles back to what you initially said, and when we're talking about target pressure and range, which is, what you were taught was, and what you believe in is that fluctuation in pressure is one of the most powerful predictors of progression. Now, if we go back to my simple understanding of the eye and a shock absorbing eye, and I'm in a car that has horrible shock absorbers, I go over a bump, I'm going to fluctuate a lot. We're going to go over that bump and I'm going to be shaking all over the place. Whereas if I have an eye that I'm in a car that has an amazing shock absorber, we're not going to be fluctuating at all. So I think you just looped it right there around with fluctuating pressure, and a good shock absorbing eye is not going to have the same fluctuation and will likely not have the kind of damage that you get with high fluctuations in a bad shock absorbing eye.
So that was some really cool stuff, because these are the issues that we face. Why are people not responding, or why are people progressing despite all the IOP? And this is where hysteresis gives us another understanding of the eye and what's really happening versus just IOP. But I want before, I know we're already at like almost 30 minutes, so I want to be respectful of everybody's time, those listening out there too. But I want to talk about some other options we have to check pressure, because we understand that the cornea can affect how our IOP is measured with Goldmann. Do you guys use any other technologies in your practices to help measure the IOP outside of Goldmann? I know Goldmann's been the standard way of measuring IOP, but are there any new tonometers that you guys are using to help adjust for that stuff?
Yeah, I think Nate has been such a on the forefront. He's been about a decade ahead of everybody in terms of this stuff, and he's really jumped and understood hysteresis before a lot of us did. And the same thing is true for the new tonometer that's out called the CATS tonometer, and that is really, I've been playing with that a lot, and I've actually switched entirely to it in my main office, because it's been shown to be it really takes into consideration the biomechanics of the eye and the cornea, and I think it doesn't have that same fault that Goldmann has, especially in low hysteresis. Right now what I'm doing often is I'm doing the ocular response analyzer hysteresis measurement, IOP-CC, but I'm also doing a CATS tonometer, and on occasion I'll pull that out and put in the Goldmann, but invariably what I'm seeing, especially in the low hysteresis patients, is Goldmann is under reading it. CATS and IOP-CC are usually dead on, and I think that's the future for Goldmann. I really think it's the data out there and the studies that have been done are very powerful. It's so hard to do studies on applanation, because we don't, and I tell my patients this all the time, we don't know the true pressure. The only way to know is by cannulating the eye, and you cannulate the eye, you're going to alter the system anyway. So it's really hard. And that's, I think, kudos to Felipe Medeiros that do the progression studies on hysteresis. And it's so hard to do progression studies on applanation. But I think we can use all that information that will help us further validate the CATS tonometer, and really show that I think it's less influenced by the cornea.
So no, that's great stuff. Thanks, Davinder. Nate, tell us a little bit, what is the CATS tonometer for those out there who don't know it yet? Does it look like a Goldmann? Does it slip onto a Goldmann sleeve, or how's it work?
So CATS, and I just have to tell the story, but Sean McCafferty is an ophthalmologist and an engineer, and he's a smart guy. But I love it when innovations come from people just doing things that, in hindsight, are totally, you're like, oh, I should have thought of that. And he basically said, you know what? No engineer has looked at Goldmann tonometry in 70 years. Is the Goldmann tip the best possible tip for measuring pressure? I mean, how could you have come up with that without modern computer modeling and all that? So he ran a bunch of regression analysis, engineering equations, and realized that a sinusoidal tip, instead of that flat tip with the roughly 3 millimeter diameter of the standard tip, he realized that he could do a little better. He could minimize tear film adhesions. He could minimize the influence of astigmatism, corneal thickness, and hysteresis. And so all it is think of your whole Goldmann machine. You keep that little tip that you take out and clean between patients is replaced with a CATS tip. So it's not very expensive in terms of anything like we usually pay for in our office. And it gives you a whole new, more accurate way to get Goldmann-like readings. And so you check pressure just like you would. The Myers on it look a little different, and that takes a little bit of getting used to. It's maybe, you got to talk to your tech before they just go check a bunch of patients with it. But it's the same principle, same reading philosophy. Interestingly, it forces you to be a little more centered, and you realize you've been checking all these off-centered pressures with Goldmann, but not really kind of doing anything about it. And it gives you a value. And I would say within a day of using it, you immediately will start finding patients where you're thinking, wow, I'm so glad to see your pressure's where I really thought it was. But I was getting all these high Goldman readings or vice versa. So it was, for me, the benefits of having the thing were realized within an hour of putting it in my Goldman.
So you don't go back and forth doing Goldman and cats. You always check it with cats, right? Once you do cats, you follow up with the cats, I assume, right? You don't go back and forth.
I would say, so again, no, you can go back and forth. And, if I have a cataract post-op and my technician's checking pressures, I'll just let the technician check, at least while I'm getting everyone used to cats. But whenever I'm checking a patient's pressure in the office, I'll use the cats. And, and usually it's good news. I mean, and that's one of the things too that, sometimes been tough is, we don't like to have bad news for patients. And sometimes a low hysteresis isn't the best news. But thick corneas, high hysteresis often add stress that doesn't need to be there. And so you can tell a lot of patients good news.
It's interesting. With the CATS tonometer, it is also less influenced by how much fluorescein is in the eye, and the Myers get distorted if you're not dead on, exactly like Nate said, and so it forces you to be dead on, and you can cheat a little bit with Goldman. And then the other thing that's annoying with Goldman, obviously, is you put a drop of fluorescent in the eye, and then you have to wait or you have to dilute it because the Myers are just so thick. You don't get that with CATS. So. Sean has done such a great job with innovating that tip, and just like with hysteresis, I joke that this is a safe space, but you go to some of these meetings and you talk badly about Goldman appination, and you're going to get booed off the stage. So I don't think people are ready to accept. Although most people I think will admit that Goldman is flawed, but I don't think they're ready to accept yet a new applinator tip, although they should. And it's going to be just like Nate said about hysteresis. 10 years ago, people looked at him like he was crazy, and now people look at him like he's a genius, as he should be looked at. But it takes a while to catch on.
No, I have to thank both of you guys, because I don't even remember, Davinder, that we had the Glaucoma Forum Congress meeting in Chicago. We invited you to speak at, and you gave this awesome hysteresis lecture. I wasn't using hysteresis at the time, and as soon as I got that, I heard that lecture, I called the OR people. I'm like, man, I need this now. That was amazing. And then I called Nate, and Nate was like, here's how you use it. And it was just like, oh my God. And it really has changed my way of approaching glaucoma. And the more we learn, the more we realize, as we all know, the more we realize how much more we have to learn. And just, it's about opening up your horizons, being open to new options and new paradigm shifts, as we're seeing with glaucomas. It's always ever changing. And I think hysteresis and CATS tonometry are giving us a better understanding of what we really thought we knew, and maybe challenging us a little bit there. It's always hard to be challenged, but I think we have to be open to that challenge. So I thought this was awesome. You guys rocked it. I learned so much from you guys. So thank you for taking the time, and thanks for all your knowledge and expertise. And hopefully we can get a chance to hang out soon. But thank you for the hysteresis and CATS tonometry talk, and just for overall friendship. Anything you want to say to the audience before we go?
No, this has been good. Thank you guys so much for doing this. So good to hang out with you and learn from both of you. And this has been a lot of fun.
Yeah, always great to see you. And I feel it's a great opportunity to just hang out and chat with my friends. And of course, unfortunately, I was born with a demented mind that loves to talk about glaucoma. So tonight checks both those boxes. So thank you guys for a fun night.
Thank you, everybody, for hanging out with us tonight for another edition of Dose and Delivery. Again, thanks to Nate and Davinder. Awesome time. And stay tuned. Hopefully, we'll have another episode in the future. But in the meantime, stay healthy and stay safe. And we'll hopefully see you soon. Take care.
Thank you for tuning into this episode of Dose and Delivery, the podcast. If you have feedback or topic suggestions to share, find us on Glaucoma Today's Instagram, LinkedIn, Facebook, or Twitter. Stay tuned for more hot topics in glaucoma care on Dose and Delivery, the podcast.
Dose and Delivery.